Welcome to another edition of OrthoCarolina's monthly webinar series. Tonight's topic is shoulder arthritis. I'm Dr. Nady Hamid, and with me tonight is Dr. Shadley Schiffern. We are orthopedic surgeons at OrthoCarolina's Shoulder and Elbow Center, and we have a clinical focus on, you guessed it, shoulder and elbow. So tonight, this is being live streamed on Facebook, LinkedIn, and YouTube platforms. Again, the topic is shoulder arthritis. We'll start off with some basic fundamental information, and we'll cover some questions that patients commonly have about shoulder arthritis. We'll talk about what symptoms patients experience when they have shoulder arthritis, and then we'll get into some of the funner topics about what treatment options are available in 2024 for the shoulder arthritis. So I'll begin. I'll pepper Dr. Schiffern here with a few questions about shoulder arthritis to give you some basic information. So Dr. Schiffern, tell everybody, if you could, what is shoulder arthritis? You know, there's a lot of times there's some confusion patients will have between the words arthritis, tendinitis, bursitis. So what exactly is arthritis of the shoulder?
Yeah, Nady, I think it's important to initially, when we're talking about the shoulder, talk just basically about the anatomy. So the shoulder really is made up of the humeral head, which is the ball of the shoulder. That's the top of the arm. And that sits in the socket of the shoulder, which I'll show you here, which is the outermost part of the shoulder blade or the scapula. And covered around the ball and socket joint are the tendons that make up the rotator cuff. So that's another term that you commonly hear around the shoulder. These rotator cuff tendons go completely around the ball and socket joint, and they are very important at holding the joint together, giving the joint stability, and then also allowing for all the range of motion around the shoulder. And so when we talk about arthritis specifically, what we're really talking about is a disease process that causes inflammation and then wear and tear over the surfaces of the humeral head or the ball and the socket. And so arthritis is a degenerative condition that starts to cause breakdown of the cartilage surfaces over the ball and socket. And the cartilage, we like to say, is that kind of glistening surface that helps to provide smooth motion through the joint. And it also acts as kind of a cushion or a shock absorber. And so when you think about the cartilage wearing down or breaking down in a joint, whether that's a shoulder joint or other joints in the body, that loss of cartilage, you lose that smooth surface. And so it starts to cause issues with mobility of the joint. And that can manifest itself as stiffness or decreased range of motion. Also, the cartilage breakdown leads to inflammation in the joint, and that's what typically starts to cause pain. So I think in our practices, the most common things that we see patients presenting with arthritis are pain in the shoulder, as well as decreased range of motion.
Where do they usually have pain, Dr. Schiffern?
A lot of this pain is kind of, patients describe it as deep down in the shoulder. So it's not a pain that you can oftentimes put your finger on, but just a deep kind of dull, aching type vague pain. The other thing that we definitely see, though, is that a lot of pain from the shoulder can also refer a little bit down the arm. And so we see a lot of patients who will describe that they say, oh, actually, it hurts in my arm, but actually the disease process can be in the shoulder. So there is a phenomenon of some referred pain that goes down the arm as well.
Yeah, I find that patients are usually actually quite surprised that the problem they have is actually deep into the shoulder, because, as you said, it hurts down the arm more. Typically, shoulder arthritis doesn't give you pain deep in the back of the shoulder up to the neck. It's almost classically just right here on the mid part of the arm. The other thing that patients typically have is they can have relentless nighttime pain with this. You know, Absolutely. They just wake up with this toothache pain just right over the mid part of the lateral arm there. Okay, so why don't you tell me, if you have a patient with shoulder arthritis, Dr. Schiffern, you start telling them about their diagnosis, their condition. Tell me about some options to treat the arthritis.
Yeah, very early on, once the diagnosis is made, there are several things that we can do from a non-surgical standpoint to really help minimize the symptoms that patients experience. From the pain standpoint, you can use over-the-counter medications, things like Tylenol, which can help minimize pain. The non-steroidal anti-inflammatory medications, things like ibuprofen or Aleve, are oftentimes helpful to minimize some of the arthritis pain, especially when there's a flare-up. Sometimes we see that these symptoms kind of fluctuate. And so all the patients who feel pretty good for a couple months, but then they'll have a flare and it kind of hurts more. And so if you can get people through some of these exacerbations, sometimes they'll do well on a longer term basis. There are also some topical medications, some types of anti-inflammatory gel or creams that you can use around that help to minimize pain. And then one of the other options that we do on a selective basis are injections in the shoulder. And so you probably have all heard of cortisone injections. Cortisone is a type of steroid which acts as an anti-inflammatory. And so if we can put an injection right down into that joint cavity, the injections can help to calm some of that inflammation down and help with pain. And so I think, we both in our practices, we use cortisone, but we try to use it sparingly. It's not a fix-all for these problems. It's more of an aid to try to help ease off the symptoms. And I think it's important to say that those injections aren't meant to cure the arthritis. But when used appropriately, they can help kind of get you through a bad phase. I think other two important points are activity modifications. So, there are certainly some activities that are worse on the shoulder. And if we talk through patients and can figure out which activities are really causing a lot of their pain by changing some of those activities or knowing what to avoid, that can be very helpful.
Yeah, great.
What has your experience been with physical therapy for this problem?
That's a tough one. That physical therapy is not going to cure the cartilage loss in the shoulder. We know that. But some patients can have a lot of stiffness in the shoulder. Maybe if the stiffness looks like it's out of proportion for the amount of arthritis, I'll frequently send them to therapy to see if we can get better flexibility. And I think there is some opportunity there. And I don't think you burn any bridges by trying it. And frequently patients will want to give it a shot. So especially with early arthritis, if the shoulder's a little stiff, I will try it.
Yeah. I think one other point to mention from a non-surgical standpoint that you hear a lot about in the press are these types of biologic medications, biologic injections. And so you may have heard people talk about stem cell treatments or PRP, which is platelet-rich plasma. The idea behind these types of treatments are introducing growth factors into a joint, which may help with the arthritis. And I think at this point in time, at least in our opinion, the data is a little bit lacking on showing a really beneficial response of curing the arthritis condition. I think, there are some anecdotal reports of it helping with pain, but for me, the literature that is out there on these types of injections for shoulder arthritis just have not gotten to the point where we're using them widespread, at least in our practice.
Yeah, I agree with that. I mean, there's a lot of really smart people that are putting great work into it. So I think there's great promise for it in the future. I just don't see it in 2024 really being a predictable, reliable, pain relieving solution for shoulder arthritis. So, okay. So Dr. Schiffern, you have a patient, they've tried the anti-inflammatories, they've tried modifying their activities. They've done, maybe a strategic cortisone injection here and there. Their x-ray shows pretty advanced arthritis. What would you say would be the best treatment if they tell you, Doc, I'm fed up with this thing, I got to do something?
Yeah, I think it's important to have that discussion, as a patient, to have that discussion with your surgeon about when is the right time to pull the trigger on thinking about surgical treatment for shoulder arthritis. And that's really different for every single patient. It really comes down for me, to how much it's impacting your quality of life. So is it causing pain on a daily basis? Is it interrupting your ability to do activities of daily living, simple things around the house? And then just as Dr. Hamid mentioned, the nighttime pain often is really what brings patients in saying, I got to do something because I'm not sleeping well at night and it's really wearing me out. So when we start thinking about surgical options for the shoulder, there are a few. In very early arthritic shoulders that have not had complete cartilage loss in the shoulder, an arthroscopic treatment can be considered, where we go into the shoulder minimally invasive with a scope, and you can do some debridement and kind of some cleanup work to kind of smooth off some of the cartilage surfaces, help to do some releases around the shoulder to help with that stiffness to improve motion. But I do think it's important to say that the arthroscopic treatment is pretty limited to that early arthritis. It's very hard to have really successful results with arthroscopic treatment once the arthritis gets bad. Would you agree with that?
Totally agree with that.
And so really the mainstay of treatment for severe shoulder arthritis that has failed non-operative treatment is shoulder replacement surgery. And that's something that both of us in our practice are probably one of the more common procedures that we perform. And just to show you what the shoulder replacement looks like. So as we talked about, the normal shoulder has the ball and the socket. When we enter the shoulder, we actually make a cut across the very top part of the ball. And then so it would look like this. And you have a metal stem that is implanted down inside the canal. And then a new metal ball attaches to the stem. And so you're basically replacing it or resurfacing it with a metal ball. And then on the socket side, where that socket is inside the shoulder joint, we are actually just resurfacing that socket with a polyethylene surface socket that gets implanted into the bone. And so when we put the two together, it ends up looking like a nice smooth articulation between that metal ball and that plastic socket. And shoulder replacements have really come a long ways since we started them.
Yeah, I remember, 12 years ago, we would do shoulder replacements, and patients would stay in the hospital 3-4 days. They would get tons of narcotics, and it was a tough deal for patients. Now in 2024, we do them as an outpatient, minimal narcotics. We take advantage of non-narcotic medications to help mitigate pain and discomfort, and patients can bounce back pretty quick. It's still a major surgery, but we've refined our techniques and the way we can have patients recover much quicker than they could years ago. So
I think also along with that, the implants themselves have continued to evolve, throughout our careers. We thought this was interesting. This was a very rudimentary prosthesis that Dr. Hamid came upon. This prosthesis was actually implanted in a patient way back in the 1950s, if you can believe it. So it's not too dissimilar to what we're using today. But the implant that we use now, and there are several companies who manufacture them, and so the design work has really been aimed at restoring anatomy. So these prostheses we use now really try their best to replicate the anatomy that we're taking out. And the ways that we fix the implants into the bone have improved. There's different ways to secure the implant, and so they become a much more durable operation. I think the longevity of how long these implants last have really come a long way in the time we've been practicing.
I do like the way this one looks, though. I may start going back to this. Okay, well, maybe you could tell us a little bit, Shad, about recovery after shoulder replacement. Patients, they're not sure what to expect, and maybe just some kind of general guidelines of when patients can kind of get back to some normal semblance of life.
Yeah, it's a really great question. And I think early on after the surgery, and this would go to part of the surgical technique, when we go into the shoulder to do that work, we have to access the ball. And gosh, I keep moving the wrong direction. Sorry. We have to access the joint. And to do that, we have to detach this very front tendon of the rotator cuff. It's called the subscapularis tendon. So we detach that from the bone, and that allows access into the joint to do the work. Now, at the end of surgery, we have to repair that tendon back to the humerus. And so we use heavy stitches and sutures to secure that tendon back to the bone. And that is very crucial in these replacements, that tendon heals for the shoulder to function well. So for many of us in the first month or 6 weeks, we go pretty slowly with rehab to protect the repair of that tendon. And so, I'll oftentimes have patients wear a sling just to give their shoulder protection for about a month, about 4 weeks. During that time, I do let patients come out of the sling to do, just basic, kind of daily activities, things in front of them. As long as it's not heavy, they can move right away, but we just really want to protect the repair of that tendon. So first month, 6 weeks, a little bit slower. We definitely get them moving in physical therapy. We start, letting them work on range of motion. And I think for most of our shoulder replacement patients, by 3 months, they're really back to doing most of their regular, day-to-day activities. And that's typically when we start advancing them with some further strengthening, maybe start kind of a returning back to recreation or athletic activities. I start chipping and putting around 3 months and kind of work up from there. I don't know if that's a similar protocol for you.
Yeah, exactly. Yeah, exactly the same. I mean, most patients want to get back to light to moderate recreational activity. The most common sports people want to get back to after shoulder replacement is golf, swimming, tennis, and then light strength training at the gym. I think those are the most common things. And I would think that all those activities are totally doable after a successful shoulder replacement.
And definitely pickleball. Don't forget pickleball.
Fastest growing sport.
I think for most of those activities, I do tell folks, before you're really back on the course playing or out on the court, playing, you probably are thinking more along the lines of 6 months to be, playing back at your full level. But between that 3 month and 6 month window, you're really making good progress.
Yep. I want to remind our viewers, we're being live streamed on Facebook, LinkedIn, and in the YouTube platforms. And please submit questions. We have a little bit more we want to discuss, but then we'll be able to answer questions at the end. Okay. We wanted to briefly touch on a different type of shoulder arthritis that is actually extremely common, and we call it rotator cuff tear arthropathy is sort of the scientific term for it, but it's basically rotator cuff arthritis. And so what that means is when you have a tear that develops in your rotator cuff, meaning you start to have tearing where the tendon of the rotator cuff tears, and if the tear becomes quite large, what can happen is the ball tends to ride up too high on the socket. And when it does that, it doesn't have the normal alignment. The ball isn't sitting correctly on the socket. The ball tends to ride up high because of this rotator cuff damage that's probably taken place over years. And so then you start to develop secondary arthritis. So it starts off as a tear in the rotator cuff. And then secondarily, you start to see the changes of the cartilage surfaces like Dr. Schiffern mentioned. And so that's a different type of arthritis that we actually treat differently. We'll initially treat it the same with therapy, with injections, anti-inflammatories. But if a patient fails that type of conservative management, we would consider a different type of shoulder replacement that many of you may have heard of before. It's called a reverse shoulder replacement. And I want to just briefly tell you what that looks like and what it means and why we do that. And so what a reverse replacement is we put in an artificial ball and socket, but we put them in backwards. We put in the artificial socket where the ball used to be, and we put the artificial ball where the socket used to be. So it still has a smooth articulation, but we've changed the ball and socket to a ball and socket. And it sounds like a crazy thing to do, but it really is it boils down to physics of the shoulder. And when we change the center of rotation of the ball and socket joint, and we shift the center of rotation, what it then allows is it allows the exterior muscle, the deltoid muscle that overlies your rotator cuff. It then allows the deltoid to do 90% of the work when lifting your arm, and it doesn't rely on the rotator cuff. In a normal shoulder, the deltoid and the rotator cuff act together. They both do about 50% of the workload. Well, when the rotator cuff is damaged, like you see in this rotator cuff arthritis, doing the reverse replacement now bypasses the need for the rotator cuff, and it harnesses the strength of the healthy deltoid. And so we're able to get an arm then that has the artificial joint that provides pain relief, but also the deltoid muscle that can now power the shoulder. So you get both restoration of strength, but also with pain relief. And so that's how the reverse replacement works. It's a surgery that has a pretty typical rehab and recovery than a conventional shoulder replacement. Patients usually in a sling for a month. Maybe the recovery is slightly easier than a regular shoulder replacement. But the long-term success rate is about equivalent. We've been doing these reverse replacements in the US since 2004. So we have right at 20 years of data and follow-up on the patients. And what we're seeing with 10 and 15-year clinical outcome studies is it's about equivalent, with about a 90% 10-year success rate, which is about in line with the regular shoulder replacement. So very promising results. We're still learning more and more about the reverse replacement as we have less long-term follow-up with them. But 20 years now of follow-up it's getting to be one of the more reliable surgeries we have in orthopedics.
Yeah, I think it's an operation that has really become revolutionary for us to treat a very difficult problem that before this was designed, we really didn't have a good solution for those patients. So it's really helped us be able to provide care and a good solution for those difficult problems. I know one question I commonly get from patients is, why would you do a reverse replacement on me versus why would you do the regular anatomic replacement? And really, a lot of that is dictated by the status of the rotator cuff tendons, just like Dr. Hamid mentioned. And so I think the reverse was designed for rotator cuff deficient shoulders. I think it is done in some cases for arthritic shoulders, but the reason for the decision for one versus another usually has to do with the status of those rotator cuff tendons, in addition to what the status of the ball and socket joint is.
Well, great. Maybe we'll have time for some questions now. So we'll see if there's any that have been submitted. Oh, here's a question. Okay, first one. I have bursitis in both shoulders. What can I do to be able to get back to golf?
Well, I think bursitis is an interesting problem. It oftentimes you hear patients talk about bursitis versus tendonitis. If you hand me this model here, Nady, the rotator cuff, as we mentioned, covers over the ball and socket joint. And this space above the rotator cuff tendons is a very tight little space. You can see the top of the shoulder blade sits right over the rotator cuff. So there's not a lot of room in there. There is a thin layer of tissue that we call the bursa that sits in between the rotator cuff and this bone above. And what happens with repetitive activity is the rotator cuff rubbing against this bone above could cause inflammation in that space, in that bursa space. So that's really what bursitis means. And so if you develop this, oftentimes it comes on with repetitive activity. It is something that can be very well treated without surgery. A lot of it relies on some physical therapy exercises, which can help with range of motion. It can help with strengthening these rotator cuff tendons. An anti-inflammatory approach, as we talked about, both with oral medications, occasionally an injection to help settle things down. But most of the time, if you can really, rehab through this, you can get back to all activities, including golf.
Yeah, I would fully expect that too. The way I like to think about how patients develop bursitis is, the deltoid muscle will drive the ball up, and the rotator cuff is supposed to keep the ball lower. And so a lot of times when you get bursitis, it's an imbalance between the deltoid and the rotator cuff. And so if you can do a good therapy program that strengthens your rotator cuff, it'll essentially help keep the ball lower in the shoulder, and it'll help prevent it from rubbing and getting pinched by that shoulder blade bone above. So I've found physical therapy to be extremely helpful for bursitis. So I would recommend getting in to do some therapy, maybe some anti-inflammatories, and then get you back out making birdies again.
Next question is, can arthritis in the shoulder cause range of motion and general weakness in the arm? And can it also affect the neck area, causing stiffness and pain? Or is the neck a separate issue? Great question.
Yeah, we see a lot of overlap with symptoms from the neck and the shoulder, because a neck issue, especially a pinched nerve, can create shoulder pain. And a problem within the shoulder joint can create shoulder pain. So you have to be kind of careful, especially if you have stiffness in the neck or pain that goes up into the neck area, that may be related to more of an underlying neck issue. Like we talked about earlier, the classic area to have pain for a shoulder condition is the mid-arm area. And so it could be two different issues, or certainly it could be all stemming from the neck. And I would probably want to, from what I hear in this question, I would want to take a deep dive into the neck before chalking up all the symptoms to the shoulder joint.
I just would throw just one more point in there too that I tend to see is that when your shoulder is really bothering you, your body sort of subconsciously guards, and so you a lot of times tense up these muscles up over the top of your shoulder and around your shoulder blade, and so that compensatory change in there can also lead to some of that stiffness and tightness around the neck. So those can be secondary issues as well.
Okay, next question. What are options when pain reliever is inadequate? Well, there's different things you could consider with pain relievers. You can do oral, you can do topical pain relievers. Sometimes we would consider injections, steroid injections. But usually when we have a patient that has tried the therapy, the anti-inflammatories, and they feel like the pain relievers aren't working, we may want to consider getting imaging. So that would be x-rays or maybe even an MRI scan to see what the issue may be, and is it something that we think and feel confident that it would get better with more time and more therapy, or is it something that we don't think will progress well and has a poor prognosis, and we may want to consider other options.
Yeah, so I think that would be the perfect time to set up an appointment to come see one of us to look at it.
Yeah.
Next question is how to tell the difference between arthritis versus a tear. That's another great question. And oftentimes it is very difficult to tell because just as we've mentioned, arthritis pain can bother you down the shoulder and can kind of cause that aching pain. So can a tear. And both of them can lead to decrease in range of motion. Both of them can lead to some degree of weakness. So oftentimes it's difficult to know without a good physical exam and potentially, as Dr. Hamid mentioned, getting some imaging studies. We typically get x-rays to look at the ball and socket joint to look for arthritis. If we're suspicious for damage around the tendons or a tear, then that does sometimes lead us to an MRI.
Yep. Yeah, totally agree. Yep. Do replacement shoulders get arthritis? Yeah, good question. No, they don't actually. When you have your shoulder replaced, we resurface the cartilage surfaces to where getting arthritis of the shoulder would not be something you'd have to worry about. When shoulder replacements do have problems down the line, there can be different things you can encounter. Sometimes the plastic itself can wear out, and that usually is something that happens over a long period, very slowly, many, many years. You can see some plastic wear over time. And the other thing people can develop is you can develop tearing of the muscles around a shoulder replacement, and that can also lead to symptoms or increase in discomfort with a indwelling shoulder replacement.
How early can we detect arthritis in our body? That's a tough one. I think the arthritis presents differently for different people. We see sometimes patients can have the exact same looking x-ray, but have different levels of pain. And so it's sometimes difficult to detect arthritis when it's very early. You don't always know that it's there. You usually start to detect it when there starts to become enough inflammation that it triggers pain, or sometimes it may not even be pain. You may notice that I can't move my arm as much as I used to be able to move it. But it can be difficult to detect early on.
Well, the tricky part, and I think I know where this question is going, is can you detect it early? Can you prevent it? And that's the big question. And unfortunately, we don't know of any way to prevent the progression of arthritis right now. And so even if we know someone has early arthritis, there's not a medication or a surgery or a treatment we know of to halt the progression of the cartilage deterioration. There's a lot of people worldwide that take glucosamine chondroitin, and there may be some loose evidence to suggest that it actually helps. It's easy to take. It's over-the-counter herbal supplement. And so if somebody does have early arthritis, a lot of times I'll counsel the patient about different things that they can consider doing, modifying their activities, and certainly maybe consider taking glucosamine. Bone on bone in right shoulder, still working out despite limited mobility and pain. Should I use heat or ice after workouts? What other options besides shoulder placement surgery? Well, it sounds like you're getting by okay. And patients can be extremely surprising with how well they can cope and compensate for a very bad x-ray or a bad shoulder. If somebody's getting by and they can still do the things they want, they're able to kind of modify their activities, anti-inflammatories are working, then we'll certainly hold off on surgery and save shoulder replacement as a last resort. But that's where you probably want to, you want to work on stretching exercises. You want to really pay a lot of attention to how you're working out and finding the things that you can do without aggravating the shoulder, finding the things that do and avoid those things. I would typically recommend icing after a workout and maybe strategic use of those NSAIDs.
Yeah, it's always a good question that we get asked about, heat versus ice. And, I do think some patients find good benefit from using heat. I typically think about, heat before you're active or before you work out. But after a workout, I would agree with Dr. Hamid that icing probably afterwards is a better mode. So I've been diagnosed with the goat's beard in both shoulders. What's the best way to deal with the goat beard?
So the goat's beard is arthritis, and they call it a goat's beard because patients will develop a bone spur around the bottom of the ball of the shoulder that I guess to somebody resembled a goat's beard. And so that's basically a way of describing arthritis of the shoulder. And so best ways to deal with it is the stuff we've discussed. You want to try and think about taking those medications we've discussed, modifying your activities. And the other thing is you probably want to just keep an eye on it too. And we typically would recommend patients get about once a year or so just to monitor the progression of arthritis. Most of the time, arthritis of the shoulder progresses really slowly, but there are times where it can progress pretty rapidly. And we want to know that. And if the shoulder is getting bad in a hurry, there are technical things that make it more challenging if you do require replacement in the future. And so we just don't want to get surprised if somebody comes in 5 years after an initial x-ray and things have gotten dramatically worse, and now maybe we've lost some options to treat them.
Next question is, do you think that turmeric and ginger are good for inflammation to try for arthritis? I do think that there are some of these, natural supplements that, patients report some relief of arthritis type pain. Whether or not it has any effect on the natural history of the arthritis or prevents that arthritis from getting worse, I don't think there's much evidence for that. But certainly if it's something that you can take that's safe and may help alleviate some of the pain, I think it's reasonable to try.
Yep, agree. What are lifting restrictions after replacement? That's a controversial question. We try and have patients get back to enjoying their life, using the shoulder for the things they want to do and enjoy to do. But this requires lots of talks before and during the recovery after a replacement. We try and discourage patients from getting back to heavy weightlifting or heavy manual labor work after replacement, just because we want to make that shoulder perform for many, many years to come. We want to increase the longevity of the replacement. And so it's a tough answer to give a number to. I generally tell patients like things I think that are a little excessive for it. Like I don't like patients hanging and doing pull-ups. I don't like it when patients do dips. I don't like a lot of heavy bench press work. And And it's typically exercises or lifting that requires the pec muscles and the deltoid and the shoulder. And those are the things we want to be pretty careful with. But, these are questions that, it's different for everybody. Everybody wants to get back to a different level of activity. I would say in general, when patients are ready for a replacement, the trade-off for them, the pain relief and the way they can get back to enjoy the things they want to do far outweighs the sacrifices they have to make with some of their activities.
Yeah, I would agree. I think, I try to have that discussion of, you can still, and patients ask all the time, can I still work out? Can I still lift weights? And I think you certainly can, but you got to just make a little bit of a mindset change that, maybe lighter weights, more reps, changing some of the activities. And you can still build good muscle and have tone and not put a lot of shear stress on your shoulder. The other thing is there's a lot of different types of lifting. So, if you're lifting something down here at your waist level, like lifting a bag of fertilizer, that doesn't put as much stress on your shoulders if you're lifting a heavy bag in the overhead on the airplane. So I think that's certainly there. And Dr. Hamid is absolutely right. There's different types of lifting that we'd rather you not do after a shoulder replacement, but I don't put a strict weight limit on my patients either.
Will I be doing more damage to my shoulder by continuing to work out if I have bone spurs? Probably. Shoulder arthritis is a condition that will worsen with time, even if you don't do anything, but you'll likely accelerate the wear in the shoulder arthritis by doing things that put more and more load on the shoulder. And so it's definitely a spectrum of activity. And so I typically counsel patients on avoiding things that really bother the shoulder when they're working out. If they know a few activities that really flare your shoulder up, you're probably not doing yourself any favors of slowing the progression.
Yeah, I would agree. Is there less range of motion or mobility from a reverse replacement compared to a total shoulder replacement? I think that's another very good question. And I do feel like even in where we're at now with reverse shoulder replacements, they do tend to have a little bit less range of motion in total if you compare it to a standard or anatomic shoulder replacement. And the main motion that patients can lack is what we call internal rotation behind the back. So that would be, reaching your arm back behind you. Sometimes that can be, getting to the belt line back there or hooking a bra. That motion tends to have a little bit of restriction, but it is variable from patient to patient. I think both of us have seen some of our reverse patients who have really great motion. So I think across the board, wouldn't you say the reverse may have a little less range of motion?
Yeah, I would definitely say that. And, I would say in general, we always try and do the regular shoulder replacement if somebody's a candidate for it. Yeah. And typically we do the reverse replacement when someone's not a candidate for the conventional shoulder replacement. Because I do think the motion is a little bit better with a regular replacement. Yeah. Good question. You explained shoulder replacement recovery, but what about the cleanup procedure recovery?
Yeah, I think certainly a cleanup procedure recovery can be a much faster recovery than going through a shoulder replacement. And part of that is because we don't put any restrictions on you in that early period of recovery during a cleanup. The cleanup procedure you do arthroscopically, so it's minimally invasive. You're not having to detach any of those muscles to get into the shoulder joint. So we like to have patients start removing the sling and start moving their shoulder right away after a cleanup. So their recovery can be certainly faster.
Definitely faster, much more, it's minimally invasive, but the downside is it's just unpredictable. It's hard to predict how much symptom relief and for how long the symptom relief will last for. I have a tear, arthritis, and severe foraminal stenosis at C3, C4, and moderate foraminal stenosis at C4, C5. So foraminal stenosis, for all the viewers, is arthritis and narrowing in the spine, in the cervical spine area. Will injections help with the pain I'm having both in my neck and shoulder? I would think that injections in the neck would be more helpful than injections in the shoulder. But it sounds like there's two different things going on here, right? A shoulder with considerable arthritis and a tear, and then also the neck. In general, I have patients get the neck evaluated first and see if there's any treatment necessary for the neck, whether that be injections or therapy or even surgery. Kind of want to get a plan with that, and then we can move onto the shoulder joint from there.
I would agree with that. How long do shoulder replacements usually last? It's another really hot button question. And I think that we're finding that some of the longer term outcome studies now with the new generation implants is even better than it was prior. You know, some of the longest term outcome studies on shoulder replacements going out, 20 or 25 years have really showed very good survivorship. So there have been some studies that showed 80 to 85% of patients still doing well with their shoulder at 20 years. Those studies were obviously done 20 years ago. So the implants and the technology we have now is likely more durable and better than it was back then. So unfortunately, the question is we can't really tell you with 100% certainty how long the implants last, but we're seeing less and less issues with wear of these implants.
Yeah. How can I prepare my muscles prior to shoulder replacement surgery? I think that's where physical therapy can be helpful. Doing strengthening exercises. One of the biggest predictors of range of motion after shoulder replacement is what was your motion going into the replacement. And so I do like patients to try and maximize their flexibility and their strength of their shoulder as much as they can. I mean, within reason. It's hard sometimes if you have a bone-on-bone arthritic shoulder to do a lot of that. But I think within reason, it's helpful to try and optimize function prior to the replacement.
Yeah, physical therapists can be very helpful for that. One other point just to make too is when you think about the shoulder motion, how you move your shoulder, there's movement through the ball and socket joint, and there's also movement of the actual shoulder blade itself. So some of the muscles back on the back of the shoulder blade are important to strengthen too. And then a physical therapist could help you to really strengthen those muscles, which will help as well. Well, I think we've run out of time for tonight. We wanted to really thank you all for attending the OrthoCarolina live webinar. A replay of this event will be posted on our social channels. And we really had a good time doing it. Thank you all, and good night.
Good night. Thank you.